All right, so as we kind of get this going, I'm going to keep watching people pop in here. Yeah, so we're going to be talking about digital denture workflows today. And again, just as an aside, this is probably the area with digital workflows that I've been maybe most focused on over the last, I don't know, maybe 6 months with Lee and learning different ways. We started with immediate dentures primarily because it's just a great way to start when you're working towards all on 4, all on 5. So, getting the teeth out, getting a denture in, maybe loading it or not, that was the workflow we started with. And now we've done a couple of edentulous cases that Lee will go through and kind of talk about what we do from that end. But again, what sort of blows my mind about it is just the fit of these things compared to other ways. And what I also really like about it is that, like in the edentulous workflow, if you can reline what they have and scan that and take some pictures, once you bring that into 3Shapes, it feels like you're doing a diagnostic wax up, basically. I mean, you're making basically the same decisions about where teeth will go. And so I'm just liking how all these things are interfacing in a way that is just so seamless. And then the other thing that I think we can talk about is that as we start printing and doing these other things in our own offices, depending on how far you want to go with this, then you still have that same decision about how much are you going to do, how much are you going to rely on the lab to do for you. And that's where it's really interesting coaching you all, because it's very different from practice to practice. Some of you continue to want to just be able to do the evaluation and have primarily most of the outputs done by the lab. And then other people are wanting to do more and more things completely in-house. And that's just kind of the natural progression, I think, with what's happening. So for those of you that don't know, I want to talk a little bit about when Lee and I met. And you might not know this, but we've known each other for a very, very long time. My first year in practice, I went and saw Dr. Dawson for the first time, and then decided to go to the Hinman Dental meeting in Atlanta. My wife had family there, so we went, and I'd gotten to know Dr. Dawson a little bit, and he told me I needed to go to a house that was owned by a very well-known named lab technician named Raymond Gold, who owned a laboratory there in Atlanta. Mm-hmm. And I met Lee there, and we were both about the same age. Lee had actually been to the Dawson Academy quite a few times by then, because he didn't go to college for 8 years. So his career started earlier than mine. But we've kind of had this connection in terms of a belief in putting a lot of emphasis on where teeth go from an aesthetic and functional perspective. And then we just kind of went on our own journeys. And as you know, probably he's been involved with development of materials at Ivoclar, Empress, and Emax. And again, once the digital thing hit, he's been involved with just about everybody. So with that, I mean, I'm really enjoyed my little coaching thing last year, but really excited about where this is going now that we've partnered up. So with that, I am going to make Lee the host.
Great. Okay. Hey, good morning, everybody. So John is right. We both started about the same time. Obviously, Dr. Dawson has influenced our lives, and for everything we do, and I still base pretty much everything I do off of 30 years of education or more with Pete. And then we became all very good friends, and sad with the passing, but it still continues. So it's just in a different way. I still remember, so digitally, I saw my first glimpse of digital was 35, 38 years ago at the Hinman meeting when Francois Duray was speaking. And it was just amazing. I mean, and there was nothing back then, but just with him talking conceptually about what he was working on and what was happening, nobody could predict what we have today. So we're going to talk about specifically digital dentures today and kind of my history and what we're doing there. But we can literally do anything you can conceive of, we can do digitally. Just as a short note, I was in surgeries yesterday with the company Neosis and their digital implant surgical robot Yomi. So I was speaking at the Amos meeting on surgery and restorative and the way we do things digitally. And they approached me after the meeting, and I didn't really even know what it was. And we've gotten closer and closer. So I'm going to be helping them on their team with kind of formalizing and streamlining their surgical restorative. But there was a robot placing implants yesterday. I was watching. I'm watching, but they programmed the implant placement in. The drill was set in the approximate location of where it was supposed to be. And then the robot said go, and the surgeon still applies pressure to push the drill, but it can't move. It stays where the patient is. So, I mean, that was just thoroughly amazing to watch yesterday. So anything you can conceive is going to be done and is being done. So one of the coolest things that we have today is where John and I working together 20 years ago, he would send me a piece of paper and an impression and a shade and maybe some photographs. And then we would get on phone calls or, do whatever and try to communicate as best we could to do the case the right way for the patient and for the restorative dentist. So today, digital means so much more than just making something. CAD/CAM is making something. We're going to print a denture. We're going to mill a crown. We're going to do whatever you can think of. But digital is communication. So John and I are always, like he is with you in coaching, he and I are always looking at cases together, whether it's Zoom or whether it's TeamViewer. I know what he's thinking. He knows what I'm thinking. And then if we bring a surgeon in or a periodontist, all three of us are on the screen at the same time, negotiating on three different aspects: restorative, laboratory, and surgical, where the best places for the implants are. So whether it's dentures, whether it's crowns, the communication aspect of what we have today with digital is far oversees almost anything else, is the communication and the visualization that we have when we're doing cases. So let's see if we can make the screen move.
Try to click right on the slide itself.
There we go. Okay. So I took a lot of flack in the beginning of digital from technicians and basically got hate mail, attacked in meetings. We had to literally throw one guy out of a lecture that I was doing at one time because I've been talking about digital since the beginning of digital. We were the first digital laboratory on this planet, working with Sirona to develop the in-lab system. So I went to Sirona and go, this is cool. How do I get involved? Can I buy one of these things? I said, this is very, very cool. And then we developed the Sirona in-lab system. So we've been digital since you could be digital. But one of the things that has come up, not so much anymore because now it's a little more mainstream, but I literally just used to get attacked by technicians going, you are taking away every bit of craftsmanship and artistry and everything we do by helping all these digital companies. And I'm like, no, I'm not. I said, it's just a different way to do things. It's not better. It actually is better, but it's not taking away artistry. It's just you can apply your artistry in a different way. So the digital team is all of us today, every member of dentistry, because we'll create patients, virtual patients, and then we may be meeting with surgeons, periodontists, restorative dentists, orthodontist, because we can do anything with the teeth on the screen virtually to let the team see, excuse me, what the possibilities are. So we're also kind of redefining roles today in what we do. Because I do a lot of clinical dentistry. It is interesting to note that John and I both have daughters who are dentists today. Mine practices in Florida. John practices with him, but my daughter Tamara is down in Florida. But she was one of the top digital students in the school because of obviously her relationship with her dad, but she's been digital again since school started. So if we look at just technicians, historically, there have been crown and bridge technicians that make fixed ceramics, bridges and things, and then removable technicians. And I'm kind of leading up to why I do dentures. So I have been and trained as a crown and bridge technician. So we have crown and bridge technicians and we have removable technicians. And there was a very definitive wall between those two types of technicians and what they could do. I never did, and I've never, if Kim's out there or anybody else, I have never made a conventional denture in my life, nor would I even know how to do it. I wouldn't know how to do it, and I've never made one. So one of the reasons I was actually brought onto the denture team in the beginning was because I had no preconceived notions. So I'm a clinical technician today. I design surgeries, I do orthodontics, I do periodontics, I do anything you can think of. I basically, in the laboratory, does the heavy lifting for dentists and dental teams, restorative teams or diagnostic teams to build the patient and then give me direction. I'll go do everything and kind of do all the heavy lifting for everybody. And then we can all get on and negotiate where we want to go from there. So, but I'm very strong in clinical application today. You are all now technical dentists. So technical dentists have been around for a while. It obviously started with CEREC over 30 years ago. I know John was with CEREC and I was with CEREC, from way in the beginning at CEREC 3. And if you think what you do today is kind of cool, you should have been with us in CEREC 2 and CEREC 3 before 3D teeth existed on screen. We just had a bunch of lines on our screen and had to interpret what those lines were and hopefully create something that would go in the mouth. I remember the first time the CEREC team came over to the US from Germany because I'd been working on this 3D thing with them. And they came in and they put it on the projector and they showed me a tooth rotating on the screen. And I said, okay, the world is fixing to change. I called up Bob Ganley, who was the CEO of Ivoclar after they left that day. And I said, Bob, I just saw, you got to start working on this stuff because what I just saw was absolutely amazing and will now allow dentists and technicians very easily to create restorations. So you're all technical dentists today. Now, the fun one, because I speak at a lot of surgical meetings, is restorative surgeons, where surgeons are not really just concerned with where the bone is. They're very concerned about how the final restoration is going to work. And it's really amazing when we have that team on a screen and we're kind of everybody's explaining what their needs are. But restorative surgeons, I mean, that's just one of the most exciting things that all the restorative surgeons, from Amos to full oral surgery meetings, to the perio meetings, to the restorative meetings, but restorative.
Hey, Lee,
yes.
Real quick, I'm just going to, we got a few people in the waiting room still. I'm just going to pause you for 1 second.
Sure. All right. So redefining roles and what people can do. For the 4 that just joined, I was just talking about redefining roles and what we do as a dental team today. I do a lot of virtual planning from ortho to restorative to surgery to whatever you can think of. Technical dentists is what you are today because you're learning the software that I use. And then restorative surgeons who are really looking at planning implants and surgery based on the final restorative outcome and not just where the bone is. So we're all digital technicians today, and we're working very closely. My laboratory is absolutely 100% totally digital. I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 robots that work all night when I leave here, both milling and printing. So everything that we do, everything that we create comes out of a mill or a printer. And we'll be talking about printing today also. This is what a digital laboratory looks like. We don't really have a lot of the things that a conventional laboratory does, or even my laboratory from the past does. And it also allows better production just on a laboratory side, just to talk about the laboratory for just 1 second. But we can do actually so much more work now per person than we ever could before. So we're still small. Our laboratory is small. We're still considered boutique laboratory, but our production that we can create with this technology is really amazing. And the things that we can create and the amount of work we can do on a daily basis. There we go. So let's move into digital planning. These are the data sets that you're very aware of that we need. Intraoral scanning and CT. With those 2 data sets, literally we can do pretty much anything you can think of. We do a lot of orthodontic work here, at least visualization. We do a lot of perio work here. And it was interesting, I was going to post this one. I just had a periodontist send me a CT and an iOS to make him a guide to show him how much bone he would need to reduce to get the tooth contours that he wanted. And once I got it on the screen, I'm looking at it and measuring, and I called him up and I said, honestly, you don't need to do any bone work. I said, here's your tissue thickness, here's your bone. This is all soft tissue work. So one of the things we see in digital is we come in with a preconceived notion of what we want to do for a patient, and I immediately was able to tell him, this is easy. I mean, this is all tissue work. I'll make you guides to show you, optimally where your tissue should be, but you don't need to do any bone work. And it was kind of cool that he's like, wow, that's really cool, that because I would have been flapping tissue and doing all kinds of things. So we're able to do a lot of things. So we use a lot of different softwares here to do those things. And I said one time on WhatsApp, if anybody ever needs anything printed out, or if you'd like me to take any of your CTs and transfer them to STLs to print, we're happy to do that. It takes very special software to be able to do that and do it very nicely. And it segments, and we can do segmentation and pretty much anything that we would want to do with a CT scan to be able to print it back out. So artificial intelligence. So the software that we use is actually based on artificial intelligence. It used to take Matt 2 hours to transfer a CT into an STL and segment and everything else. Right now we use artificial intelligence software, and it comes back in about 30 minutes completely done, and we didn't really do anything. We can always go modify it and change it, but artificial intelligence is going to get much, much bigger in what we're doing today, to the point of doing all the designs. I mean, we're already seeing it. And it's funny because Sarek has had this and been dominant in this area for over 30 years in tooth positioning proposals. But now we're going to start seeing it in larger cases. We're going to see it in dentures, because if there's one thing that I've learned in dentures is there's very definitive anatomical landmarks and measurements and geometry to do a denture. So feeding that into the machine and letting the software just design your denture for you, we will see not too far away. I mean, it's already being worked on. Robotic manufacturing, everything here is done by robots. Augmented reality is something we'll talk about in other Zoom meetings, some things that are out there for patient education and some of the things we can do. We're already using augmented reality for patient education. So the one thing that was very important to us that has gone off the market is Bellis. We don't even know why they went off the market. We've been working with Bellis since day one. when we kind of called them up with others to bring it into dentistry. Their face scanning has been around for a long time. It's not new, but it's incredibly expensive. I mean, we were looking at anything from 15 to 25 to 35, $40,000 for face scanning. So it never made sense. So Bellis was a phone app that worked very nicely. We've now lost that. But it's funny, we just are in communication with a company out of Asia that contacted us because they now have a non-phone app facial scanner with high integrity that's actually not expensive. I mean, in the realm of dental stuff. So we've got one of those coming. I'll let you know how that's looking and how that's working, because face scanning was actually very important to us, and we were starting to incorporate it into our denture work and what we're doing. So I used to travel a lot. Obviously, we're really not traveling that much anymore. So my technicians, when I was gone, would scan themselves and print their little heads out. We did this to a really good friend of mine, Dr. Lyndon Cooper. He did a face scan to us, and it's down, and we printed him up a little body and sent it back to him. So now that we start to really move into it, creating that virtual patient was very important to us. And that's why we're really looking to something to replace Bellis so we can get that in, because it kind of was the missing link for us. Because, you know, we had photos, and, you know, we can put photos, two-dimensional photos on three-dimensional data, and that's good. But being really able to have the face and being able to see all this information together, at least for the laboratory and building the virtual patient, was incredibly important to really designing these more complex cases. And it was a phone app, worked very nicely. We could tie the CTs into it. So we could do an intraoral and a CT scan, tie all that in, and then put the face on top of it. You know, helps for positioning on the digital articulator. There was a lot of things that we could do with this data that we still can do today. So we were doing a lot of training with universities on the digital face bow that we helped them develop. And actually, we were really sad to see them go, because we did a lot of work for them. So when we are looking at diagnostics, whether it's dentures, whether it's crown and bridge, you know, we have so many tools today to be able to do those things. We also do a lot of smile design work here, just very quickly. We do promote having dentists do it and having the software, because you can do it so much quicker than sending the data to us and sending it back. And then orthodontics and all the things we can do with the software that we have today, because we can do some amazing things. Now, strangely enough, I can do incredibly complex surgery and make all the guides for you to do that surgery with. And I am covered under FDA to be able to do that. But I cannot make an orthodontic tooth movement vacuum form guide. You can as a dentist. I cannot as a technician. That's a more complex FDA area that costs a lot to get into. So I can do surgery, but I can't move teeth. It's kind of interesting that what we've got. But all this data together allows us to really have what we need to do any type of diagnostic for our patients, whether it's dentures or whether it is anything else. So as we move into dentures and we start to look at what we can do with dentures, this is where I got involved. So I got involved on the denture part. So we were doing dentures before there was denture software. Before there was denture software, we still figured out how to do a denture. And then I did a presentation to the American College of Prosthodontics maybe back in 2014, 15, where we were doing monolithic setups. So I really kind of started moving into dentures. when I was at Microdental in California. So I was running that laboratory, and one of our biggest areas of money loss was fixing hybrids. And I really didn't know a whole lot about them, but I'm looking at my sheets and I'm going, okay, we're losing money here. Why are we losing money? Teeth falling off, repair, 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 repair. And I said, oh, okay. Now that I understand the problem, let me see if I can come up with a solution for it. So I did this presentation at the ACP before really as digital dentures were starting to get going, because in the beginning, everybody's thought process was we're going to mill or print a base, and then we're going to take individual denture teeth and glue them in the holes, which I always thought was stupid. That made no sense to me. So we were the ones who figured out monolithic dentures. I did this presentation at the ACP, and Ivoclar comes up and goes, how did you do that? And how are you doing that? And then we got together, and it was actually a big deal on Ivoclar's part, because Dentsply is the #1 seller of denture teeth in the world. Ivoclar is second. So when they gave us the power to make our own denture teeth, they basically just made denture teeth obsolete. Now, there's still denture teeth out there. There's still people using denture teeth. Their denture teeth, as soon as Ivoclar made that decision, denture teeth are going away. It's not going to be tomorrow, but denture teeth will go away because we can make our own denture teeth now. Why do we need to buy denture teeth and glue them all in, unless you're just doing what I would consider antiquated techniques to make a denture today because of what we can do. So what you're looking at, when we started doing this, we started milling the denture teeth, and we had to figure out some ways to get it done. But what you're looking at is a base, a denture base that is one piece, the pink, that is milled out. The teeth are a bridge of teeth that we milled out. So they're not individual teeth, they are milled teeth in one big 12-unit bridge that fits into the base like a puzzle piece. Ivoclar's first go at this, I thought, was kind of cool. So what they would do is you would mill your denture base kind of halfway, except for all the sockets were perfectly milled. And then you would mill your denture teeth kind of halfway, but the bottoms of the teeth were milled perfectly. So you would mill your denture base, and then you would mill your denture teeth, cut your denture teeth off, and then glue them into the base, ready to go back into the mill. And then you would bond them together with some PMMA, some softer material, some methyl methacrylate, and then you would put it back in the mill, and it would mill it all out and clean it all up in the excess PMMA. And I did that one time and go, okay, I thought that was cool. This is kind of, I just didn't agree with it, because you had to take things out of the mill, you had to put things back in the mill. So we did the proper Ivoclar technique one time. And then we figured out how to change the settings on the files, where we could mill the denture complete to finish, and we could mill the teeth complete to finish, and then we would bond them together. And I'll show you why. But that's what you're looking at here. This is my teeth that I pre-contour before I bond. So all the contours are like I want it, and the tissue's not in the way. But those are not individual teeth. That's a big bridge. So this was where it really started in the lecture I gave at the ACP, showing what we were doing. This is actually the first case that I ever did, maybe 10 years, well, maybe about 8 years ago, right as digital dentures were just starting. Avident was coming out. Everybody was kind of talking digital dentures. But we had a hybrid in the laboratory, and they were fixing to take all the teeth off, put all the teeth back on, process it, and do it again. And I said, no, just give it to me. Give me the case. So we just scanned the bar in on the model, and it looked like that. It was just an existing. We cleaned it up and then scanned the bar on the model. And then I designed teeth on top of the bar. I bridged them, and then one of the techniques you use to make temporaries and other things cut to gingiva. So I put the teeth where I want them. I cut to gingiva. It cut them from the bottom so it fit perfectly back on the bar. And then we milled out the teeth and bonded it to the bar and added a little tissue composite to the front. This is where monolithic dentures started, with this case right here. So it looks like this, fits perfectly over the bar. And it was kind of a workaround with software that we figured out. And you can see the cutout on the bottom, they literally fit perfectly together. There's the bar, there's the teeth. And then we would bond that to the bar, add composites for the tissue, and call it done. So our remakes and adjustments on hybrids literally stopped. Now, not to say there's not one broken out there today. Now, they will still wear, it's still PMMA, but we were just not getting teeth popping off because they're bridged. It's one big solid chunk of PMMA. So there was nothing really to break off. Now, they would still wear. Now, the cool thing about this, assuming the opposing dentition didn't change that much, when the doctor called up and said, hey, it's wearing, what do we do? Well, I just go to the file, mill another one out, send me the bar back, and then I'm going to basically burn that one off and take all the existing, put the new teeth on, bond it all back together, and send it back out again. So that's, again, one of the cool things we can do with digital is repeatability. But this is the first case, and that's where we started doing monolithic tri-ends. So then we started really looking at creating the bars. We were creating the bars out of titanium, chrome cobalt, some of the new polymers that they're around today, and we started making our own bars and designing the teeth at the same time. So designing the teeth and the bar at the same time, placing our holes, milling everything out. Sits on top of the bar, looks like this, put our screw access holes in. And this was actually with a polymer. So we were trying to do something that we could mill in the laboratory, because back then we couldn't mill metals in the laboratory. We can today, but we could mill the polymers very, very nicely. And then we would bond all that together. We started creating printed metal bars. So we printed our metal bars, and then once we had the mills that we could mill, then we started milling those in-house. So we really started doing a lot of work in this area with milled teeth. And this is really where it started, because Ivoclar was still on when the Ivoclar project started, it was all about milling a base and gluing in existing individual denture teeth. Now, so then we moved to digital dentures. So in the beginning, you could design a base and mill that out or print that out, then buy the denture teeth and glue them in the holes. And I'm like, okay, still, that doesn't make any sense. So again, I've got amazing people here. I said, all right, take that file, because you still have to design your denture teeth. You're just not going to do anything with them. I said, take that file, attach them to the base. I said, I don't care if it's one color, just attach them to the base. So then we started making dentures, milled dentures, but they were all one color, because you couldn't do anything other than glue into denture teeth, and I didn't want to do that. But this was the most fun, and this is, again, we started getting a lot of attention here. Before there was denture software, we would just trick the software to do a denture. Now, this is an overdenture, so it's going to be a little bit different. And this is a patient that we're going to restore. He's not old enough for implants yet, but he was at the age that he was starting to get peer pressure from his peers, because they were kind of making fun of his teeth. His mom brought him to the dental school and goes, is there anything we can do? And this is another case I did with Dr. Cooper, and he was halfway through doing an overdenture in the regular analog way. And then he calls me up and he goes, hey, can you do this digital? And I'm like, I have no idea, but let's see if we can. So here's our patient. And again, like I said, he had already started the workup, establishing vertical, where the teeth positions go, and already done that in wax. So I kind of had a diagnostic guide to be able to do the digital part when we moved to it. And it looks like this once we started to digitize. And again, we were using models. This is not intraoral scans. We were scanning the models that he had actually started his diagnostics of. So this is his initial wax up with real denture teeth and real wax. And he tried it in the mouth and everything was good. And he was going to go to processing when he called me and said, hey, is there anything we can do here? And I said, well, let's send me all your data. Let's see what we've got. So he sent me the models, he sent me the wax ups, and then we started to digitize all of this information back so we could mill it out. So he's already figured out pretty much everything that I need to know. So I didn't have to start over. I just had to really copy what he had done and then go into the mill. And the gingival. Okay. So quick wax up in the mouth. Everything looks good. He likes it. He sends the data to me and I start to digitize. So what I did was I really just took the data once I had the teeth in position like I wanted them to. And again, we're going to use that cut to gingiva tool. And then I just started taking the kind of the modeling tool, the rubber tooth tool, where I could stretch and pull the data. And I just pulled it down, pulled it over the tissue, pulled it into the vestibule, pulled it over the lingual, trying to keep the teeth as accurate as possible, but just taking that data and really pulling it until I had a denture base. And you'll kind of see how it all works out here. So there's our wax up, there's our digital design, putting everything together. There was his denture and then my denture. And you can see and this is an overdenture, so I really don't need a palette, but I just pulled it right over. And the overdenture is going to be on the teeth. That's the reason I say it's an overdenture at this point. There's his teeth, there's our new teeth. And we just pulled the data down into the vestibule. And when we got it to where we want it, we did cut to tissue, which eliminated everything from the bottom, which gave us our denture fit. We did then add composites to the facial for tissue. And it looks like this. So this is ours. So it's actually a comparison of what he did to what we milled and how close we were able to get to his original design. So that's upper acrylic to lower wax on one side, upper wax to lower acrylic on the other side. And again, totally monolithic. So he's trying it in and he sees we have actually enough vertical room within the acrylic. So he bonds on the posteriors because we had enough room on the upper and lower, maxilla and mandible. He bonds in locator attachments actually on the teeth. So he just bonds them to the teeth and then hollows out the denture and then cold cures the retainer into the denture. So it really just snapped into the patient's mouth. We didn't start with that idea. It was just something he kind of thought of on the fly when he was putting everything together. So it looks something like this. Fits over the teeth, snaps into place. And our final first denture we ever did with no denture software, because there was no denture software at that time. So this is a monolithically milled overdenture with composites added to the facial to give us the pink tissue. And it ended up looking something like that. So our first denture ever. Here's the lower. And then we polished. So here's our 13-year-old boy with his new teeth in his mouth. So he when he got his new teeth in his mouth, he actually dyed his hair because he's got a really beautiful smile. And this was many, many years ago. So here he is after he got his new teeth in. He's got a beautiful new smile, dyed his hair blonde, still likes that necklace that he has on. And then we just started playing with the software. So we figured out how to trick the software into making bite blocks. So and we just tricked it. So we would actually design two copings. We would take the tissue, we would design just one big coping that went everywhere on the tissue that we wanted it. And then we went to and applied a bar on top of it. So before, we could do bite blocks, we figured out how to do bite blocks, and then we're printing those out. Right in the beginning, when the printers were, then this was some of the newer, smaller printers we've been printing for many, many years. But those printers, when I started printing, were anywhere from $80,000 to $250,000. Formlab, which this came out of, Formlab was the printer that really changed dentistry and printing in general, because now anybody could print. But Formlab is the one. I mean, there's a lot of printers out there. Formlab totally changed dentistry in that anybody could buy a printer. I remember lecturing one time, and I think I sold 50 or 60 printers during the lecture. I said, because nobody really knew about this stuff. And I said, okay, everybody, I want you to take out your phone. I want you to go here. You can buy it with your phone now. The Formlab printer is not 80, not 60, not 30, but it was $4,000. I mean, I think 60 people bought printers in the audience just that day. So we figured out how to make bite blocks. And then starting to use all of that information to create dentures. Now, again, same thing. We had dentures, but it was still designed in the beginning to glue in conventional denture teeth. And then we modified our files to be able to take that denture, that monolithic denture, and just mill the whole thing out of one big piece of acrylic. So that's the way we started. So I remember when I was doing some of these dentures in the beginning, when we kind of figured out this technique, and I'm a Cranham bridge technician. So, I didn't honestly know any better. So in Cranham bridge, whatever you make has to fit your model, and you have to be able to occlude it and check it. So I'm like, well, dentures got to fit the model. So I couldn't get, now that Dr. Cooper and I were doing this more and more, the first one I couldn't get to fit the model. And my wife calls me one night and she goes, "Are you coming home?" I said, "I've milled this denture 5 times and I can't get it to fit." And she goes, "What are you talking about?" I said, "I can't get it to fit the model. It won't fit the model." She goes, "Baby, dentures never fit the model. There is no model." And I'm like, "Well, how do you check it? How do you know if it fits? How do you know if it's going to go in the mouth?" She goes, "They just do. It's okay, but you're never going to get it to fit the model." And I'm like, okay. But this was our first monolithic dentures. And then we would add composite to the facial. Same thing, we started doing more dentures and then milling them all out monolithically and then adding composite to the front. This is where 3Shape and Ivoclar go, okay, well, maybe we can mill the teeth. And that's kind of where all this started. So why am I doing dentures? I'm a Cranham bridge technician, and we honestly don't do a lot of dentures. We don't, we do it for customers. We do it for friends. I don't advertise that we're doing dentures. Most of the dentures we do are generally diagnostic workups for final implants, and that's why we do dentures. But they asked me to be on the denture development team because I had no preconceived notions of the way things should be, and we changed everything. So this is Dr. Nadeem Baba, Eric Kuchka, who's a really good friend of mine. He's a denturist up in Canada. Then my wife, and then Dr. Lyndon Cooper. We all kind of work together on these projects. So when we started putting it together, this is when the research started. So we can mill, we can print, we can do everything. So I wanted to see all the different options. And you're looking at that going, so, and the really red ones are wax. So we could actually still mill wax and still process if you want to. Like if you definitely want to process denture with teeth in it, we can mill the wax and we can still process it conventionally with Ivacap or whatever other way. The light pink ones are obviously milled base materials in the beginning. The really dark red ones are printed wax that we could still process. We've got many different ways to do teeth. And then on the back row, we had all the printing that we were testing, because we tested everything. And this, this is kind of back when it started. So we were doing a lot of testing to see what options we had, because the main question here in digital dentures is in everything. You always want to ask yourself this: is it different or is it better? So with dentures, it's definitively better. Dr. Cooper and I did Dr. Cooper, the main guy at UIC. He was Dean of Research. So we did a 24 patient study to really see the workflows, the fit, patient satisfaction, longevity, and just to really see, is it different or is it better? And we objectively could check off better on almost everything, not almost everything, everything you could think of, from occlusion to aesthetics to fit to strength to patient satisfaction. And we'll go over that a little bit later in the day. So the other thing, and again, I don't like to do partial dentures, but we wanted to see what we could do. So this is an upper denture that has been milled base and teeth are bridged together, bonded together. But then we designed a lower partial to go with this case because it was one patient. And we designed the lower partial in the computer digitally. And then I sent it off to a place that prints RPD frameworks out of Chrome Cobalt, and they fit like crowns. I mean, literally, the fit on these things is immaculate. So what I did was, when I got the frame back, I scanned the frame into the computer, and then I designed the 6 anterior teeth that you see there to fit on a framework that we had already pre-designed vertical struts that the teeth could fit right over. So then we bonded the teeth to the framework and then added pink composite to the lower. So again, we just want to see what we can do. I don't want to get a framework and then have to go and process the teeth, because I don't have any processing equipment here. I've got to be able to do it with a printer or a mill, or I can't do it. So the framework was printed, Chrome Cobalt, came back fitting perfectly, already polished. It was really, really nice. And then we scanned that in, designed the teeth to fit on the partial, and then added composites to the facial to get the pink. So why was I able to move into dentures actually pretty easily? I learned how to do dentures in 2 days. Not a master at all. I just learned how to make a denture. My education, over the last several years has gotten a lot better, but so I was certainly no master on day 2, but I could make a denture and it could go in the mouth. But a lot of it was because of what we do here in the laboratory, which is full arch on implant. That's our #1 product here that we do at the laboratory. And it's not a whole lot different. So whether we're doing crown and bridge that goes on implants or dentures, the workflow is almost exactly the same. We're almost really creating a denture with teeth and tissue that just attaches to implants. So there's not a whole lot of difference between the 2 workflows. So we were able to figure out this pretty quickly. So we were able to take everything we've been doing in the ceramic world, because this is ceramics, so all ceramics, and then move it into the PMMA world. So all we were doing is creating what we've been creating for years, and just not attaching it to an implant. So John, the directions that we kind of got was to go for about 45 minutes. Questions on this part, take a little break. We're kind of at that part now. So, and I'm at a great stopping point because now I'm fixing to move clinically. So as the lead in this, do we do questions and answers now? You might be muted.
Let's take a 5-minute break right now. And then if anybody has any questions, when we will come back, we can do the questions and then start back with the lecture. Okay, that'll give everybody a chance to step away and get their thoughts together. So let's reconvene about 5 to 10, and we'll do some questions, and then we'll get into the meat of it.
Great. All right. Great. Thank you.
See you all in a bit. All right, Lee, a couple of questions with regards to face scanning.
Okay.
The first one was, if there's anybody else in here, but yeah, Sean Mooring asked, my Bellis app still works. How do you mean you lost Bellis?
So Bellis will, I don't know the exact day, and hey, Sean. So Bellis will cease to exist and support existing customers, I think, in March. So yes, it still works. Ours still works. I don't think anybody can buy a new one, and they will really start shutting down service to Bellis. I thought it was March. I'd have to really define that. Maybe Whitmix would even know a little bit better than me. But they are stopping Bellis 3D. I don't know the exact date.
And then the other one was from Ari and asked, I've already answered him, but I'll throw it up to the crowd.
Mm-hmm.
Says he wanted to know if CBCT scans, some of our new CBCT scans, now including face scan in that, and I can answer that. My new CareStream 9600 will, and one of the things Lee and I still have to test. I tried to bring the data files, both the CT and the face scan, out of CareStream, and there was some little glitches with it, but I also don't have any experience doing that. So we're going to send that down to Lee and see if that works. But the answer to your question is they are definitely starting to do that. And I think it's a genius way to do it, because then the CT and the face scan are pinned against one another. So you don't lose any of those relationships. Do you know of any of the other ones that do, Lee?
So the challenge, and this is the challenge we had with Bellis in the beginning. So Bellis was a consumer app. It was not medical dental. It wasn't until we pointed out to them how it could help us. But then the problem was I could import a Bellis scan into 3Shape, but it was not until 3Shape allowed the import of the PLY file that you could do anything with it. So you've got two files on a face scan. You've got what's kind of like a face that looks like it's made out of clay.
And a clay thing, yeah.
Yeah, the clay thing, and you can bring that in, no problem. But the PLY file is the texture file that goes on the top. It's the skin, it's the face, it's the coloring. So 3Shape allowed Bellis to bring that in, but 3Shape does not allow anybody else in. So as an example, if you're using CareStream, iTero, whatever, the only color file that I can bring in my system and actually see the color of the teeth and the tissue and everything is Trios. So it will allow me to bring in iTero, but it will not allow me to bring in the iTero PLY file, which is the colorized file. So that's the problem. Can we bring it in? Probably. Is 3Shape going to let the PLY file in? Not yet.
Okay. Gloria, how long and who keeps the files to reprint cases for patients first? And then the second one is, what adhesives are you using, and how well do they work long term when you are when you bond the monolithic to the bars?
Got it. So the bonding, we use Ivoclar bonding materials. So there's a chemical we put on the PMMA that's called Connect. It's also from Ivoclar. Connect is a chemical that allows light cured resins to bond to PMMA. Then we use monobond and everything else to prepare the metal. And then there's a couple of cements basically designed along the multi-link line. So there's multi-link, which you use in the mouth, which I also use to bond things together. But because there's so much of a gray bar there, you can do two things. You can opaque the bar or kind of make the bar pink first, which is a step I don't want to go through. So there's actually a very, very opaque cement that's designed for implants. It's basically designed from multi-link, but it's white and it's really opaque. So what we do is we take some red resin stain and we mix it with the white and then apply it to the inside and basically press it down onto the bar. And then we've got a pink opaque bonding agent to bond the bar to the PMMA so the metal doesn't show through.
Okay, cool. The last question for me is that Ivoclar Connect. If we were to use that on a PMMA, say provisional, whether it's on implants or teeth, could you reline with a traditional acrylic? Would that help that bond or not necessarily? Different chemistry.
And we haven't really seen any problems with on teeth because a lot of people reline shells with bis GMA. I haven't, nobody's reported to me that they're falling apart in the mouth. So it kind of goes in the reverse. If you're printing your temporaries and want to reline, then yes, you might want to get some Connect to make sure everything's bonding good together. If you're doing milled temporaries and want to reline with conventional acrylic, then it's the same material and you're good to go.
Okay, so you don't, at that point, you don't need any adhesive. Will you air braid or anything like that?
Yes, and we do that, and you should too. So yes,
Yeah.
you need to air braid the inside. Yes.
Okay, perfect. A couple more coming in. Sean asking, can you bond Emax teeth to the denture base?
We will get to that. So it's not a great bond, but we have done ceramic teeth on denture bases, and I'll actually show that.
All right. And then Don, last one, then we'll keep going. What glue is used connecting the teeth to the denture to the partial denture framework?
So so same thing. So I've got a milled PMMA little section of teeth, and we're going to bond it to the framework. So it's the same as bonding those 6 teeth to a partial framework as a full arch to a bar. We're going to prepare the inside, sandblast and connect on the PMMA. And then we're going to sandblast, monobond, and then multi-link cement to put them all together. So the process is the same, exact same for putting teeth on a partial as putting teeth on a bar.
All right. I'm going to just check one thing and just make sure no one else needs to come in. So let me reclaim the coast for a second. Yeah, there's
Okay.
one. There, he needs to come back in. All right. And you're back.
I got the screen.
You are the man.
Okay. All right. So when a denture comes out of the mill or the printer, it does not look like that. Yeah, we have to do a little work on it. So we'll walk through how we do this and where you can take a denture, how far can you take it with aesthetics. So the one you're seeing here was actually composite was added to the facial of the denture. just a little bit to accentuate some of the colors we see naturally occurring in the mouth, but you can do some beautiful, beautiful things with the composites and correct polishing. So again, same thing, milled bases, milled bridged teeth, but then I did add composites on top of the milled base using the connect. And again, just to get different colors, to get those tissue colors, to make it just a little more natural looking than just the one base color. So the cool thing about doing a digital denture is you can come in any way you want to. So there's basically 3 different ways to do a denture. You've got an immediate denture, and that's easy. I mean, it's just, I love doing immediate dentures. And then you have existing dentures. And this is what John and I have been doing on his existing dentures. And he can explain it a little bit more also. But basically, he takes their existing denture out of the mouth, assuming it's a fairly decent denture, and we've got a bite that's reproducible, and the incisal edges are at least in the ballpark. But he'll take that denture out of the mouth with a bite relationship and just scan it while it's in his hand, all those pieces together, and then send that file down to me, and then I can create the denture using the intaglio surface and the bite and some of the anatomical landmarks from the existing denture to create a new denture. And then you don't have any information at all. There's nothing, there's no teeth, there's no existing denture. And then you've got to come in from the beginning where a lot of dentures start. So we can do impressions and denture and bite. So we can either do that digitally, or you can send the dentures in or duplicate the dentures. So let's say you've got some dentures, duplicate those dentures, put a wash impression material, take them, send them to me. We start copying. We can do mush bites. I mean, if you really want to, kind of go back in time a little bit, impressions and just bites, traditional wax rims we can do, or digital wax rims, functional impressions, and then functional impression with Gothic arch tracing. So all kinds of ways to enter the digital denture. So you don't have to do one thing, because everybody thinks, well, you got to do special things to do a digital denture, and you really don't. You've got all kinds of ways to enter the process. So impressions in a bite relationship, basically, like I said, 2 dentures in a bite. If you duplicate those or scan them like John does with a bite, then I've got all the information I need in one little packet. It's the upper, the lower, the intaglio, the incisal edge position, the bite. He's just going to take that out of the mouth and scan it, send that down to me, and then I can start making a denture. So we'll go to the way Ivoclar designed it. And I've really got to be honest here. I don't do a lot of these because normally there's a denture, unless it's just horrible. You've got something you can start from that makes it a whole lot easier. But let's say you don't. Now we want to go full-blown digital Gothic arch tracing the whole thing. And when you do it, it's not that it doesn't work. It actually works very well. But there's a couple more steps. So basically what we've got is an impression of the upper, an impression of the lower, and then you're going to pretty much take a triple tray bite like you see here, and we're going to pin that information together. So I can take the triple tray denture bite and then pin the other 2 impressions to it, excuse me. Now, in the Ivoclar system, in the Ivoclar workflow, there is a face bow that we kind of refer to as a digital face bow. It's not, it's a physical face bow. And it just aligns things from an occlusal plane and an aesthetic plane. And there are numbers on there. Now, I have a duplicate of this face bow in my software. And then I will take your numbers off the physical face bow and apply them to the digital face bow. So we've got the same relationship to the face and the teeth that you have physically, I will have digitally. So it's basically kind of an occlusal plane. And you can see we have the kind of triple tray in the mouth. We've got everything hooked to the face bow or plane. We're looking at it both from the side functionally for the plane, and then from the facial for the aesthetic plane. And John, this is just for your information. This is all the stuff I'm sending to you. You've got the face bow, but you don't have all the rest of the stuff. So
Yeah, now I'm learning what it is, so that's great.
yeah, so when it gets here, you'll know what it is. So there's a whole tray system, and like I said, we're going to do an impression of the lower, we're going to do an impression of the upper, and then we're going to do a triple tray bite for the denture. We're going to scan in the lower, we're going to scan in the upper, and then we'll scan in the bite and put all this data together. We are going to eventually get to scanning in the mouth for dentures, so I'm coming to that. There's just so many ways to do this. I'm trying to cover them all today. So impression upper, impression lower, triple tray, we pin all that into our software. And then what we're going to make is functional impression trays. So I'm going to take that information and I'm going to now make digital bite blocks, but it's also going to incorporate a Gothic arch tracing. So it looks something like this. Everything kind of snaps together in a puzzle. We've got the bite block. There's a spacer, for you to take your impressions. So you're going to put the spacer in that kind of locks the two a little bit together. Well, not locks them together, but the spacer's there so they can move around. And this is going to be your custom functional impression tray. And we're going to take impressions. So now we're going to take those impressions out of the mouth and we're going to take the spacers off, and the little Gothic arch tracing device just literally snaps back into place, and then we're going to go back in the mouth. And from here, you'll go through your excursive movements and get a very traditional Gothic arch tracing. And then when you define where your bite is based on the Gothic arch tracing, you will then lock the upper and lower impressions together with the Gothic arch tracing device in between, and it just kind of locks everything together. So it looks like that. And that is sent down in one package to me, and I start scanning. So you can do this, or if you see the little package down there at the bottom, the physical package, if this was a denture, this is what John just scans in his office with his intraoral scanner. So it's basically kind of the same information. So they all kind of interrelate, and we can show you what we're doing here, but it gives us our starting point to set our teeth. So we've got our midline, we've got our incisal edge, and then we're going to add one more little set of information here. If you have never seen a vellus, it's going to make you want one really bad. You just can't get it. So it was a phone app or an iPad app, anything from Apple that had facial recognition.
Camera. Turn left.
And this was our setup. This is my wife.
Turn to the middle.
She's faculty in prosthodontics
Turn
at
right.
UNC.
Turn to the middle. Tilt your head up. Turn to the middle. Tilt your head down. Turn to the middle. Capture completed.
Oh, that is.
And then it's going to render all of those images it just took into a three-dimensional head. There he is on the screen. And then that information would come to me, and then we could put it all together. So the first thing that we're going to do is take the information, the mathematical information from the physical face bow, apply it to the digital face bow, so we're aligned in the proper occlusal plane and facial plane. So then we're going to mark just like we do. So we're not going to wax anything. We're going to take a digital pencil and we're going to mark our borders for our rims. That will be the first thing that we do. Then we're going to check for undercuts. Once we've got our borders marked, then we just want to check our undercuts, make sure they're where they need to be, or eliminate them, or leave the undercuts so the dentures kind of lock in. And then we're going to set the teeth. Now, this is why it's kind of cool, something you may want to look at in doing digital dentures, because this is where it gets fun. The denture teeth and all the molds of most dental manufacturers are in there. We're using the Ivoclar molds here, but the denture teeth, upper and lower, are bonded together. They're one piece. So wherever I take the teeth, they go together. You know, they're locked together. So now I'm just moving them around, matching either the bite blocks or the existing denture or the existing teeth. But wherever I go, all the teeth stay in an optimized denture occlusion. So you can have kind of tooth to tooth. You can pick lingualized teeth, you know, just kind of depends on what you want. But wherever you move them, they go together as a plane. So your occlusion never messes up. So now all you have to do is position them where you want them. If they're a little wide, because you do have different molds, different widths of molds, you may have to try one out. But if the arch form is a little wide, say to the distal, you can tilt them in. You know, you can close them in a little bit to follow the ridges a little better. But when you do that, when you make a change to arch form, the upper and lower still stay together in perfect optimized denture occlusion. Now, when you get them to where you want them to be, we can go to the tissue. Now, once you get them where you want them to be, you can unlock the arches and go to individual teeth. So if you want your laterals flared, if you want your centrals a little bit longer, if you want your cuspids more dominant, you can unlock and move the individual teeth where you want them to be, and then lock them back together. Now, when the tissue on the bottom of the teeth, it's difficult to see on this little picture, but around where the CEJ is, there's a little green line, which is the margin of the tooth. So on the denture, you've marked your denture base, and the teeth have a mark around the gingival areas. When you do your tissue, literally all you do is push a button and the tissue goes from your borders to your teeth and just fills in. I mean, it's one button, your tissue's there. Now you can customize it and do anything you want to with it. You can change your gingivals, change your papillas, you can put texture on it, you can do anything, but your main tissue, when it comes in, is done automatically. Now, from that point, like the teeth, you can do anything you'd like to customize it to get it the way you want it, if you don't want just the standard denture setup. So to do a digital denture is actually really, really fast. So here's the teeth kind of all locked together. Now I've unlocked them. So from here, I can start to change teeth. So on the anteriors, I can rotate, I can tilt, I can make them longer. You know, basically anything aesthetically that you would like to see, we can do. And then the kind of fun part with this is if you did have a face scan, then if you're looking at different ways to do your teeth, different shapes, different inclinations, you know, the patient can look at them and see exactly what you're doing before you ever produce the denture. So we can unlock and change all the teeth and do anything we'd like to. So all the tools you have in Dental Designer, whether it's morphing or adding, subtracting, all those tools are still in this software. Now, the last thing we would do, so one of the things that is difficult is to get the occlusion perfectly balanced bilaterally. So pretty much all the teeth are wherever you go are hitting wherever you need them to be. So once we get the teeth set and into place, Then we're going to set the articulator, either using average settings or you can do custom settings. And the teeth, the mandible of the articulator is going to start moving around, and anything that's in the way that would keep all the teeth from having perfect bilateral balance wherever you go in the mouth, all of those areas just get wiped out. So now you have perfect bilateral balance and the computer does it automatically. Now, the fun thing about the face scan is here, which we can pin everything together and then adjust the teeth, because we've never been able to do this before, even though when we think we've got it right based on anatomical landmarks, we can still go adjust. We can look at arch form, we can look at teeth, we can change teeth, we can change aesthetic arrangements for the patient, and then go to final. So now we have our final design. We've designed our teeth, we've designed our tissue, we've done our occlusion, and now we're ready to go to the try-on. Now, we did a lot of things with the digital denture system with Ivoclar. We did one time and never did it again. So we didn't have a lot of printable materials back then. So this was their suggestion, that they gave us just a white disc and you mill it out for try-on, which is okay. You know, you can do fit, you can do occlusion. Aesthetics is difficult because you can't see anything. I mean, everything is white. So I did not like that the first time we did it. We had already had some printers. We did have some test resins for teeth and denture bases. So we did this white denture, this monolithic white denture one time, and then immediately went to printing. So there's our try-on. And as you could see, there was a tiny little cant. So I wanted to lift the posterior teeth up a little bit, and there's a kind of a cant to the entire arch, which would have taken hours to fix conventionally. All I did was reopen the software and tilt the posteriors up, tilted the left side here, and we're good to go. I mean, it took 10 seconds instead of hours. And then bilateral balanced occlusion based on the articulator, adjusting all the occlusion for us. Now, we immediately went to printing all of our try-ons at that point, and we still print all of our try-ons, and we'll talk about printing versus milling and why I made the decisions I did. So back in the day, there was only one resin that you could use, and that was from the company Dentures. So they were the only ones that had pink base and white teeth. It's the worst material aesthetically ever been on the market, and the Dentures people are really, really nice, and they think it's the best thing that's ever been created in dentistry. It was really bad, and I'll show you why it was really bad. But we print the teeth in a bridge, we print the base. So bases, teeth, and then we snap off the supports and put them all together and try it in the mouth. Now, digital dentures are really easy to make changes if you get the bite right. So this is important to know. If you get the bite right and go, Lee, it's canted, or I want to do this, or the patient would like her laterals twisted, or whatever, so easy to do. Open up the file. I can change vertical. I can open it. I can shut it. I can make the teeth longer. Do anything you want if the bite's right. So this is important. If the bite's wrong, we basically start over. So you're going to take the dentures that are close, but the bite's off, and you're going to put a wash impression in the upper and lower, and you're going to put them in the mouth. You're going to bite, adjust whatever you need to do to get the bite right, and make any marks on midlines or whatever. But then, and the reason you want to do a wash is because we have to rescan and we have to start over. So we're going to mark everything. We're going to do everything. We're going to use the same mold of teeth and go put them back into the position you had them in the first place. But if the bite's wrong, we start over. If the bite's right, we can do anything you'd want. and pop it right back out to you. So important to know in digital dentures. So this is kind of how it started with Ivoclar. You mill the teeth halfway, you mill the denture halfway, and then you bond them together while they're still in the disc holders, and then you re-mill them to final mill. Like I said, we did that one time and never did it again. So there's our teeth. There's our disc. We mill full now all the way. And there's our set of milled teeth. So it doesn't really matter whether it's milled or printed. This is what they come out looking like. Now, for the average denture, this is actually pretty good. You can take it out of the mill, don't touch it, bond it into the base, go to your pumice and polish it up and put it in the mouth, and everybody's good. We tend to work at a higher level than that. So what I'm going to do here is now accentuate the teeth. So, and what I'm going to do here applies for your temporaries. If you're doing temporaries, if you're doing shell temps, whatever kind of teeth you're making in your laboratory, in your office, whether you're printing or milling, the same steps that I'm going to show you here apply to the other things you do. The only thing I'm going to do different for temporaries, I'm going to glaze. For dentures, I'm going to polish. So this is how the teeth start. And even though there's pretty decent tooth separation between the teeth, you know, they're still bonded together a little bit because the burrs just can't get way down in there to fix that. And they fit like a glove. So the first thing you have to do, whether it's printed or milled, if it's milled, you have to remove sprues. You're going to be printing probably, so you have to take off supports. It's really the same process, but we have to remove supports, whether they're printing supports or whether they're milling supports. And this is just a carbide PMMA burr. Works for printing or milling, and all my burrs are from Brasler. I'm just going to take those off. Now the next step is actually separating the teeth a little bit. So, and kind of individualizing the teeth. So now here's your printed denture teeth, but they're still bonded together a little bit. So I'm going to take a tiny little disc, a little diamond disc, because the diamond doesn't bind on the resins. And I'm really just going to cut in maybe 1/4 of a millimeter to 1/2 millimeter, just to get that separation. So it's very quick, top to bottom. Change angles to see what I'm doing. So again, whether you're doing your temporaries or your denture teeth, this is the same process I use here, same materials, same steps, same everything. Now we have a little slice between the teeth. So now we have to open that slice up a little bit to get an embrasure, because right now it's just a line. So the burr that I'm using is a little Brasler burr that's shaped exactly like the embrasure I want. You can see it's a carbide burr, and all I'm going to do now is go to in that line and just take the burr from top to bottom and just take that line that I've just created and open it up into an embrasure. Very fast, very quick. So your printed temporaries would be this way, your printed shell temps would be the same way, your printed denture teeth would be the same way. Same process, doesn't really matter what we're doing. Now, this is the way we used to do it. We would use PMMA, methyl pentacrylate, and then bond the teeth to the base and then put it back into the mill and mill the extra off, all the extra cement and things like that. We did that one time, we never did it again. And then you would put it in the mill and it would finish milling and clean up all the excess PMMA. This is the way we do dentures today. So you've got your denture base you've printed, you have your teeth you've printed, you have gone through the adjustments and made them more aesthetic, and now you're ready to bond them together. So, and these are either, whether it's milled or printed. If it's printed, then we don't add connect. We want to very lightly sandblast the sockets of the teeth, and we want to sandblast, or the sockets of the base, and we want to sandblast the teeth where they're going to be attached together. So if it's milled PMMA to milled PMMA, then we would paint on connect on both sides. If it's printed teeth to printed base, we don't need to do that. We still need to sandblast and then clean them up. So what I'm using to bond the teeth to the base with is the liquid printable base. So I just poured some of my denture print base material into a little container. And then I'm going to take a brush and I'm going to paint it into the denture and then add the teeth in and then light cure them together. And we've been doing this for many years now, and we've never had one break. So this is how we make dentures today. Okay, good. So that's just printed base material that's not cured. I just poured some in a bottle. We're going to take a little disposable brush. And add the teeth in. Then we're going to take an item we've developed here, the denture clamp, to hold it together, and then we're going to light cure everything together. Once the initial is set, we're going to come back and flow in a little extra bonding material to make sure they're in there good. Add the teeth in. And then we'll do some final contouring to the base. So we've taken it out of the mill. This is exactly what it looks like with the sprues cut off. So we're going to finish up and then do our final polish and pumice. So after grinding on the base a little bit, in the teeth a little bit, we'll clean that up, clean all the dust off, and then go to normal pumicing, and we'll finalize the denture. So we add the little textures in, all the things that come with teeth and tissue. Very careful pumicing, because with pumice you can actually ruin the denture. The printed materials pumice very nicely, just like the acrylic materials. We get a very smooth surface, but retain all the tiny little textures we placed in on the tissue and the teeth to make them look real. So back to our denture, we've milled it out, we've got it all bonded together. So now I'm just going to add some composite to the front. So I'm going to lightly blast the areas that I'm going to add. And then it's not a lot of composite. I'm just adding composites to give me that natural look of tissue instead of just the base that we see here. So you can see where I've added my composites. Again, it's not a lot. So we, again, lightly blast, add connect, add our composites. And now we're ready to do our final pumicing and polishing. And the final denture looks something like this. But again, if you don't really get in there and separate those teeth, you just don't get this really, really realistic tooth to tissue look like we see here. Our final polished and insertion. So one of the things that you will see that John has also seen, and he's spoken about it, and when we say, is it different or is it better? It's better. So sore spots basically gone. I mean, not to say a patient won't have a sore spot every once in a while, but it's just not the adjusting. These things go in and just fit, especially on the maxillary. And John can talk about this also. When you put the maxillary in, you almost can't get it back out because it fits so well. So irregardless of anything else that we do, and it all depends on your impression, how good your impression is, just like a crown, good impression, you get a denture that fits so well you can hardly get it out of the mouth. Same thing on the lower. That's where we have most of our retention problems. But again, we get very retentive lowers also. But the fit, patient satisfaction, sore spots, all those things are alleviated way, way down. So patient satisfaction is really out the roof because they're just not coming back, and you're not spending your time with them coming back every week, spot here, spot here, spot here, putting the marker in, trying to figure it out, and going through all of that process. So our final denture in the mouth. And our happy patient. One second. Double slide there. There we go. Okay. So we do a lot of research here on our own and with several different universities. This was the big research study we did at UIC, but we also do a lot of materials research here at the laboratory also. So we wanted to start testing these materials. So the question we get, to mill or print, that's the question. That's the biggest question right now. So with all that said, this is what we do at this time. We print try-ins, we mill final dentures, and I'll obviously explain why. So we still haven't seen those suction cup grip fits with printing like we have with milling, and we've looked at it several different ways. Now, with all that said, all dentures will be printed one day. Every denture is going to be printed. I mean, there's just no other way, because milling, although milling is really good, you can't do, it's hard to scale because you've got one mill. You can basically do one denture at a time. You can mill two sets of teeth at the same time, but a base is separate. So you've got 3 milling sequences you've got to go through. So printing, I can print 4 dentures at once, upper and lower, and do the same thing with the teeth. So it just makes more sense. There's so much research being done now in printing resins, coming out with new resins, coming out with new teeth resins. I'm working on one with a company right now showing great promise, as other companies are too. But I think all dentures will be printed one day, especially now. So we're doing a project with Tufts on veterans, just really trying to help them with veterans. And it's a great product to help an underserved community. It's not expensive to do. I mean, you've got to have the printer, but the resins are less expensive than the mill. It's much faster. It's easier to do. So right now, I think, for the lack of a better term, the economy denture, that printing is a wonderful option to serve that community. If you want the perfect denture, then we're going to be milling, and don't know how much longer, but because everything is getting better in printing every day. But final is we mill final dentures, we print try-ins. So this was the Denka material. This is Eric. We did a lot of study in the beginning on milling versus printing just to see what was going on. And this was the Denka material when it first started. Now, one of the problems with the Denka material is it was very translucent in the base, and the teeth were incredibly opaque, and nothing was color correct. Zero. I mean, nothing was color correct. So we start milling and printing, and then we wanted to test impact strength, flexural strength, and all the other things that go with dentures. So we started doing surface analysis. We started looking at things on our master models. Carbon was the, because we had one of the first carbon systems out there. It was good, pretty much. And I have nothing against carbon. It's just a really friggin' expensive machine. And you can buy basically the same thing for a 20th of the price, with all the new printers coming out. But we looked at it both observationally and from a statistical analysis standpoint when we did surface analysis, and really looking at hot spots, really looking at the problem areas, comparing printing to milling. And this is one of the things we saw with printing, and we actually came up with a lot of printing techniques to help alleviate that. But the blue areas are the areas where you're not getting good contact, and we're comparing what we printed or milled to the original impression, scanning both, applying statistical analysis or surface analysis software to really measure the differences between the two. And one of the most important parts is that seal on the palatal seal, especially towards the lingual. So we have hot spots in the printing. We have cold spots. Hot spots are high spots. Cold spots are not attaching. And we were getting fits in the 80s. But when we started milling, our fits and our surface analysis from the original impression to the final mill, we were at 98%. I mean, it was that close. It was almost exactly the same way. So then we look at the printed materials, and the printed materials are getting better, obviously, but the original Denture material, which is still out there, is very translucent, and you can actually see the necks of the teeth through it. The milled dentures, we've got just beautiful materials to be able to work with. So printed, so the color was off, the opacity was off, the shades were off, and then the same milled denture. And again, the printed teeth in the mouth looked a little better in the mouth on the photography, but still very opaque teeth. And then milled teeth. So the milled teeth today are actually pre-layered. So they actually have kind of gingival color, neck color, a body color, and an incisal color. So they match the shade guides, and the regular denture teeth actually very nice. So milled. Another patient with milled. And we did a lot of duplicate dentures on a lot of patients just to really look. And compared printers, compared resins, compared processing, compared fits, impact strength, and then just, putting all these dentures together. So when printed dentures kind of started, because they were more economical, Ivoclar actually developed a new disc that has the pink and the red in one disc. I think it's okay for, kind of an average or economy denture. It doesn't really give me the aesthetics that I can get with doing a two-piece, but basically the little blue areas, as long as you keep the teeth in the blue areas, there's white and pink in the same disc, and it's a much faster mill, and you're only milling twice. You're milling an upper and a lower, and we're just adjusting for proper function aesthetics, but also keeping it within the little blue areas, because the blue areas that you see would correspond to the pink and white in the disc that we're going to be making. And there's our patient and our final. There we go. So this is what it looks like. So you can see the disc in the background. It's got teeth colors and it's got pink colors. And if you keep the teeth where they're supposed to be within the disc, then you actually get a very nice pink and white junction on the denture like you see here. But that is a milled denture, not a printed denture. Printed dentures are always going to be in two parts, at least for now. So then we tried printing bases, adding teeth. So when I talk modular, there's all kinds of ways to put these together. And again, we looked at it clinically, and then we did a lot of breaking, which we'll go to now. And the Denka base. So we tried with an immediate to print as we normally do. And in immediates, so we did a try-in on this one. We actually did it both ways. But immediates, I do go to final milled, because one of the other things that is a slight challenge with the printed denture is getting a reline of PMMA attached to the printed resin. So you've kind of got to go through the same process. You've got to kind of sandblast the inside a little bit, add a bonding agent that will allow your new PMMA reline to stick to the printed material. So it's just much easier on a milled denture, an immediate denture, just to go straight to milled. So it's PMMA. We know you're going to reline it in the future. So we just go straight to mill. But again, we just had translucency problems, different problems with the denture. And again, there's our printed try-in. Again, very opaque teeth, very translucent, incredibly red material. This guy does have the best tan I've ever seen on anybody in my entire life. Printed and then milled. So we did some tests within the laboratory just to see. So this was an idealized model that we created, then we put a denture on top of it. And basically, even the suction to the model, we can't get the denture off. So when we talk about prototyping the dentures, like I said, there is monolithic white, which we moved away from, and this is why we really got into printing. So then we want to test the strengths. So we printed all of the different printable base materials that were out there. We printed them on different printers. We processed them in different ways to get to the final test results. And then we did the same thing with milling. So we've got a lot of milled, we've got a lot of printed, and we're packaging all those up and labeling those and going to our testing laboratory to break them. So this is an Instron machine. Matt literally sat for 5 days because these things take forever to bend. But what we, interestingly enough, what we found was flexurally, all the materials were about the same. So whether it was processed, whether it was milled, whether it was printed, our results did not vary that much, which we were not expecting. We expected the printed materials to be a lot more brittle in a flexural test. They were not. They were all about the same. So we just sat there in a testing lab and watched these things break literally for a week. Compiled all the data and found out there wasn't really that much of a difference. Impact testing, we did start to see differences because the printed materials are more brittle than the milled PMMA materials. Again, getting stronger every day. The Lucitone material came out, was one of the first with much, much higher strength, and then others are following. So the printing materials are getting better every day. That's what I say. The printers and the printing materials and the printing processes, all dentures will be printed one day. So then we started looking at every option to make a denture. So we've got a milled base and we've got a printed base. Now, what can we do with those? We can mill PMMA teeth. We can print PMMA teeth. We can mill ceramic teeth. So somebody was asking earlier, can you make your teeth out of Emax and bond them in? Yes, you can, but having individual teeth, the likelihood of them popping back out would be fairly high. So we still keep it in a bridged arrangement. Obviously, we can't mill out a 14 unit bridge out of Emax, but we can mill out a 14-unit bridge out of zirconia. So we have done this on a couple of cases, haven't really kept up with them, to be honest with you, but nobody's called back and said, they're falling apart. But we milled the teeth out of zirconia. We did add mechanical retention on the bottom of the teeth, and then we bonded them together basically with the same process of using monobond and connect on the denture, monobond on the ceramic. Everything was sandblasted, and then using multi-link to actually bond those two together. So we've probably done 3 sets like this, not a lot, but they seem to still be out there. So we've got milled teeth, printed teeth, milled ceramic teeth. We've got a milled PMMA base with milled teeth. We've got a milled base with printed teeth. We've got a milled base with milled ceramic teeth. Then we've got a printed base with printed teeth. Printed teeth with printed base with milled teeth, and then milled ceramic teeth. And then this is where I started. So this is where I started in the dentures, because there was no other way to do them other than monolithic, that we created a workaround so we didn't have to glue in teeth. So this is something we worked on here, but so they were monolithic, so we had to use composites on the facial to get the tissue color. Same thing on printed. Now, before Ivoclar came out with their red pink disc in the same thing, there was another one out there, but it was a severe line between pink and white. It was either pink or it was white. They didn't kind of go into each other to do tooth forms. So we tried that too. And what we had to do is get it positioned perfectly. And then we would have to come back with composite and basically add papillas and around the margins a little bit. So you can see there's a definitive line between red and white, and you would have to kind of fill that in a little bit. And then Ivoclar took this one step further to get the tooth shapes into the denture base that we're milling. Milled PMMA, hybrid. And then we started doing them over bars, like we said, making our bars here, doing over the top, both with milled base, milled teeth, or milling the monolithic. And then we do a lot of clear diagnostic dentures for scanning. But we could basically do anything you can possibly think of with dentures. So now we're gonna take it up another level after we do our 5-minute break, because we're kind of at the top of the hour. And I'm gonna go into some of the workflows and research that Dr. Cooper and I did at UIC. And then we'll kind of finally come back to this, bringing the denture back into the implant workflow. So John, I'm gonna turn it over to you for the break.
That's great, Lee. This is really good stuff. Let's take 5. There's a couple questions already, but we'll hit them after the break.
Okay.
And then we'll start wrapping the last section up. It's awesome. Really good job.
Back at 11?
Yeah, back at 11.
Okay. Thank you.
All right. So a couple questions. First thing, if you could, the little Brasseler burr kit that you've got there for contouring,
Mm-hmm.
if you could get the exact burrs, and either you could even send it to me so I can email it to everybody, or throw it up on WhatsApp, or both, that'd be great. That was really intriguing to me. I think those would probably work pretty good on bisacryls too. I mean, if we're just making, but that looked really great. Don had a question about the advantages of milled versus printed dentures, but that was right before you went into it. So I think he's pretty clear. We're clear on that. Okay. But the one thing he did say was he missed what Connect was for. Can you just talk about what the Connect product does again?
Sure. So if we're bonding two dissimilar resins, PMMA being one and a printed resin being the other. They're different resins. So we have to add connect to the PMMA to get the resin teeth and the resin bonding agent to stick to the PMMA. So connect just allows light cured resins to stick to conventional PMMA.
It connects to dissimilar resins.
Yes.
Okay. All right. I think that's a good way to say it. Gloria, have you had any issues with bonding pink composite to the milled PMMA?
We still the same thing. So if we mill the PMMA, wherever we're going to add composite, we would lightly abrade and then add the chemical connect and then add the composites to it. And again, we aesthetically accentuate, really high-end dentures like that, and have had no debonding of composites.
Okay, that's interesting. So that's the key. That connect seems to be a pretty important part of what you do. All right, Kylie, expert designer. What happens if a denture tooth chips? A patient drops the denture and the tooth fractures. How is the denture tooth repaired? Good question.
So if you've got the piece of denture tooth, you can just bond it back on with a light cured resin, but the same thing. So anytime we're using light cured resins to bond two pieces of PMMA together, so let's assume patient dropped it, chunk of central is off. If you bring it back in, lightly abrade both sides, connect on both sides, a little light cured resin, whatever's in your office, bond it together and polish it back up. If we don't have the tooth and you just, there's a wedding this weekend, we don't have time to redo anything, then you can just build it up with composite. It depends on how big the break is, but you could just build it up with composite. You can also take a denture tooth like you would conventionally do, grind the old denture tooth out, stick the new denture tooth in, and try to get it in there as best you could. Also, if you've got a little time, then you just call your lab up and say, hey, mill me another denture.
So one of the questions we had earlier, and I know you might have answered it, but I actually think it was Gloria, with all these files that are being made, who saves the file? You pretty much save all your files, right, on these various patients?
Yeah, we delete them out of the system because y'all were talking about this on WhatsApp the other day. So we never delete a file. We've got files going. Matt may do it after 7 years, I think, but we archive the files because your system will get bogged down, and we do 20 cases a day. So ours can get bogged down real quick. So at the end of so many months, Matt will take them out, go put it in our server archive, but they're still there because John may be doing an implant case and hey, Lee, I need a whatever. So we'll go get it out of archives, bring it back in, do what we need to do, make what we need to make, and go put it back in. But Matt may delete after 5 or 6 years, but generally everything at the end of like 6 weeks, if it's not been designed, goes into our archives.
Yeah, and again, to think about it, we were talking about this the other day. I mean, if you have a terabyte or 2 terabyte hard drive, it's going to take a really long time for us as a dentist to fill that up because the scans and the design work that we do are not very big. And if you start bringing in CTs and all that stuff, it's one of the reasons that I haven't really gone to doing my own implant stuff. The implant studio is expensive, but when you start pulling in CBCTs, that starts to be, bigger.
Sure.
So I like to kind of design. I'm at the point now where I'm designing teeth, starting to make some shell temps, starting to make some of my own provisionals for implant cases. Yep. And I'm going to play around with this denture stuff too. And also just to be reminded, if you guys bought the complete restorative package, that has the denture software in it. You can design dentures. If you bought Premiere, the Premiere is the basic kind of restorative. That's when you'd have to add on Model Builder if you're going to print models, and you also have to add the Denture Studio. I bought Premiere initially, so I've added on Model Builder, and now I just added on the Denture Studio to be able to do some of this too. And so, my idea of workflows, what I'm thinking about is if I could get to the point where I was printing some of the diagnostics and then got those files to lead to be able to do the final. I mean, think about that. There's a lot of different ways that you can do this. You got to just think about how much you want to keep in house. And again, I may decide that it's just too much time, too time consuming to do the denture stuff in house, and I'll just let Lee keep doing it. So, question from Gloria: when starting a denture case with an edentulous patient, are your dentists scanning the ridges, making impressions to scan later, or only using the centric tray impression, asking the patient to close?
So most of the dentures that I do they have existing dentures.
Yeah.
And John, maybe you can explain, what you do and how you scan it, because then I've got everything I need right there. So for intraoral scanning of dentures, it is absolutely not predictable. So you really have to look at those scans, and it has to be complete. So if you're doing a mandible and you're looking at your final scans, because I cannot make up data. And let's say you've got, you're on the lower right of the mandible and you're scanning, everything's really good. But when you go check it, you're missing a little piece that kind of goes from the vestibule up to the top of the ridge. I can't make a denture. I can't fill that in. So if you can get a beautiful scan, and which we've done, but it's just difficult to do. Some of the things that make it easier, some of the things we've tried and done, little fiduciary markers. If you've got a big expanse of tissue and there's not a lot of diverse anatomy on the ridges, then you need to put something, fiduciary markers, little dots of composite, because those are easy to take off. But when your tissue gets really, really slick and there's not a lot of shape to it to be able to tie one scan to the other, that's when you're going to have a problem. But we have done many dentures on intraoral scans.
I would just tell you, and again, I think trying to scan inside the mouth is really tough. Edentulous areas. Maxilla is easier, but the mandible, and the place that's really tough is if you think about the extension in the retromolar or retromylohyoid, be below the tongue. I mean, trying to get a scanner all the way down in there to proper extension is difficult. So I have yet to see a patient walk in with no teeth. I haven't seen that yet. So they almost always have a denture. And even if it's terrible, I've taken now, I guess we've done like 4 cases together. Some of them are in preparation of implants, but this one lady is just a denture that we just did. And I'll tell you that when we first started doing, this is the first case that I did, and she hated her denture, so I didn't think we should start with it. So what we did is we scanned the inside of her mouth, but the problem is when you start scanning the inside of the mouth, then you got to get a bite, and there's nothing that comes together. So trying to scan where the alignment is. So we were trying to do something anyway. It got to Lee, and they were looking at it, and they called and said there seems to be a lot of spaces between the ridge. I didn't know they struggled with the bite. So I go, no, I think it's right. Well, we get the denture back and try, and it's like, it's open like a yard. And so I called him back. I'm like, dude, something happened. This is like way off. And he goes, well, does she have a denture? He goes, just reline it. And that was the first one. And so, it was a terrible denture, but I put rope wax on it and got all my borders. And then I did a really nice soft line. So it felt great. And here's the thing. Once it goes in the mouth, it was kind of canted and the teeth weren't in a good place. But if we have a good bite and you got good intaglio, and you have photographs, if you think about it, if you're doing a big crown and bridge case and there's a cant, and we see all that and we correct all that in the wax up. So that was cool. They use that as the initial data. Then we set the teeth up. And that was the one that when we tried it in, I just couldn't believe it because we were so close. But I don't know why I was surprised, because we do this all the time in restorative, where the teeth are just a mess and we do a wax up, put the provisional in, it looks fantastic. And that's what I want you to think about. So I really think that even if they're hating the denture, if you can get a good impression and you can get a good bite, even if it's not at the right vertical, just so that they've got a bite, then the upper and lower arches are going to be related properly. And then we can open bite or do whatever we want to do. And then at that try-in, they do the printable try-in, then you do a full series of photographs again. And so from that point, we're off a little bit. And again, with these things, it's 3 appointments. It's kind of amazing. So I've really been impressed with that workflow. And again, I'll find somebody. I'm getting this stuff from Ivoclar. I have not done one from scratch yet with the little triple tray and the face bow and all that. Now, Lee, am I right that face bow thing is really still just for a dentulous? You don't need it if they have teeth, right? As long as we give you teeth in a photograph?
Yep, exactly. Okay. So that's when somebody rare strangely walks in your office and I have no teeth and no denture. But again, if we're using the denture, and this is why it makes so much sense. So we've got something that may not be right, but at least it's comfortable in their mouth. But that's better than just making some bite blocks. When I was working with Ivoclar, I'm like, why do we do bite blocks? Why don't we just make teeth? Why don't we just skip the bite block thing? If we know, we can adjust it, we could grind it a little bit, but my mind not being a denture technician, the bite block thing just digitally didn't make sense. I'm like, well, let's just put some teeth in there.
It's just funny though. It's because in the removable world, that's what we did. We started with a wax block. But you're right. In the digital world, it makes no sense. How would you recommend? So let's say you do a PMMA digital denture and they wear it for 3 or 4 years, and then the ridge changes and they reline. How can you reline these things?
Can you reline it, or can I?
Can we do a lab reline? Could we put impression?
Yeah, absolutely. Okay. Yeah, no question, no problem.
Okay, so that kind of goes. We had a couple people ask that, but yeah, so Don, if you wanted to do your reline material with HydroCast, then you could do that and then send it to the lab and they could reline it. Could you
But it's funny because we're still struggling. We're here, but our minds tend to go back here. Literally, it's just as easy and probably a lot less labor if you just do a wash impression, scan it like John does, send it to the lab. We just make you a new denture and send it back. The labor is probably less to make an entire new denture than it is to try and jig it and reline it and repolish it and do all that stuff. And just a thought.
That's true. Just keep with the digital workflow. Interesting. Don is asking about the CR bite and is Gothic arch tracing best? And I'll just take that one. I do think that with dentures, one of the most difficult things about taking a CR bite in dentures is not manipulating the jaw or any of that stuff. It's keeping the denture bases seated when you're taking the bite. So the great thing about a Gothic arch tracing is you've got the flat piece in the maxilla and the little pins on the lower. And when that pin is touching the Gothic arch tracing and you're going through the border movements, the base is always seated. And so, yeah, if you go through your left, right, forward, back, and you go back to that V, the tip of that spear is going to be centric. And I just find it is by far the best way if you're struggling. But that is a very, very good way to take a CR bite record. Bola is asking, if the bite is collapsed, can you make something between the arches to make it closer to where we want it to be?
Yeah, so if you just put bite material putty, open the vertical in the mouth, make sure the dentures are seated. Then you can open and you can open it and then scan it, because that bite material in between will attach your scans. But we've still done CR cases where none of the teeth are really touching except maybe for one molar, and still are able to scan that and scan a bite and have that repeatable on an articulator and on the digital articulator. But if you got to go too far, then just put some bite material in there and open them up and scan your bite, and you'll have that bridge between the upper and lower.
Mhm. And this is one thing that I haven't run into yet. And again, Lee talked a little bit about using some of the kind of norms and some of the skeletal landmarks to determine some of these things. I was really skeptical going into this because I was always started with a record base, then I would do wax rims, then I would set the anterior 6 teeth and the lower anterior teeth and get the teeth where I wanted it, and then set my vertical. And there are all these things that we did because that's classically what we're trained.
Mhm.
And Lee's doing a lot of this on the articulator from these norms. And what I'm finding is so far, everybody that we've tried when I'm checking vertical and closest speaking method, we're extremely close. So I might have to adjust things a little bit, but it's not like we're having to move the teeth around. That's what I was worried about, that this is a fixed thing, like the teeth aren't in wax. So the one case that we got lost on was one where I didn't get a good bite, and we somehow missed the bite. And I don't know what happened if we took the bite or when it was scanned or what, but something was off. And remember what he said, that's the biggest thing, that if you don't get that good bite on that first one, like if somebody's got an existing denture and you're scanning the dentures outside the mouth and then you're putting in the mouth to scan the bite, you got to get that dead on. Or when you do the try-in, things are just wonky and off. So that's the big step.
And again, it's funny, John, that you mentioned that, because we actually did a small observational study on bite rims versus total anatomical landmarks. So I had a bite for both. We did the whole bite rim, everything. We did this on 3 patients. And then I just have a chart that Dr. Cooper made me on anatomical landmarks and just pure geometry. It's just pure geometry. And I set the teeth on pure geometry with nothing. I mean, I had an upper arch and a lower arch, and basically perfect every time. So anatomical landmarks and going through a process of measuring averages actually gets you really, really close.
Well, I think about it, that's what orthodontic surgeons do, and they're breaking people's face.
Yeah.
It's crazy. All right. And then the last one, do you ever need record bases / rims on partially edentulous patients?
If it helps you get a repeatable bite, sure.
I mean, the only thing I can think about is if you're in a situation where, because it's partially edentulous, the only time you might need it is if none of the teeth hit. Like,
well, okay, true.
If you got the teeth over here and the teeth over here, then you might need something. Yeah. Or really, as Gloria says, really loose. I think this is the loose teeth emoji. All right.
Yes.
Okay. So that would be probably a time. Okay. Back to you, Lee, that we're done there.
Okay. So we've gone through materials, we've gone through different techniques, clinical techniques, final results. Is it better? Yes, we know it's better. If everything was uneven except for fit, and this is one of the conversations that I used to have with the Ivoclar, the head of Ivoclar removables. So both in Europe and here in the US, because they're classically trained prosthodontists in doing dentures. And I'm not classically trained in anything to do with dentures. So I start to ask questions. I'm like, why do we put the teeth here? Why do we do that? Why don't the front teeth touch? Why is there separation? Why have all the teeth got to touch at the same time? Why do we do perfect group function for every tooth, and just on and on and on and on. Yeah, I'm like, why? And Frank was finally telling me one day, Lee, just stop asking questions. And I said, well, I mean, I'm not incorrect, am I? And he goes, well, no, you're actually asking good questions. So it finally came down to, and this is a generalization. I mean, this is not exactly why we do all those things at Dentures, but there's so many things we do in dentures, from the shapes of the teeth to the positioning of the teeth to the design of the denture, because dentures never fit. So we do things that aren't natural and anatomical because they never fit, and we had to compensate for a bad fit. So I'm like, well, they fit now. So do we have to do that? Do we have to do this? Do we have to do that? Do we have to do all these things? And I do see, there's somewhere in between, but, the realization finally came to me one day. Y'all have developed all these techniques over 100 years because the dentures never fit, and you had to figure out a way to keep them in the mouth by designing all these things. So it was an interesting conversation.
And Lee, that's why you never did dentures.
Yeah, probably. Exactly right. All right. So now that we understand the science, the materials, the clinical, what we can do, where we are currently with our technology and our science. So let's just take it another step to what we can do with those dentures. So we're like 80% surgical implant restorative here. That's what we do. Like I said, amazing demonstration on robotics yesterday. Just watching the robot do its thing. It was so incredible. So, and we do this, what we do. That's just, we've kind of morphed into that. And in a subsequent lecture, I'll kind of show you how we got there. Because we actually started really in the maxillofacial world, and then kind of brought what we learned there back into this area. But it sounds so common, prosthetically driven implant placement. I mean, you'd think, oh, everybody would do that. Everybody does that. No, they don't. So one of the reasons, we've kind of morphed into this place is because we really pushed that hard, but we also get some cases in that we did not design, and we're just rescuing. We're just doing prosthetic heroics just to get some teeth in the poor patient's mouth because of implant placement. And so when we do these cases, I just wanted to show you how powerful dentures are to set up an all-on-X case, when we start to do this. And again, John and I have done several also. Starting with dentures, we've got a great case right now, codenamed Thor, that was just one of my favorite cases, and we're now transitioning that into implants, into final restorations. But I just want to show you how powerful dentures are in that and what we can accomplish with the dentures. So first, if we're doing edentulous and we're setting up implants and we've got a denture and we're going to do a double scan technique, the most important thing to remember, if we are going to put fiduciary markers on a denture and we are going to do a double scan technique, then you always need to put a wash liner in that denture. And this is why. The guide that's sitting on the tissue, and we're assuming tissue borne for this, excuse me, the guide is only going to fit the tissue as well as the denture fits the tissue. Because when we do that scan, that double scan of the denture and the CT, it's taking the intaglio surface of that denture, and our software is going to extract that out. And that's what we're going to be making a guide on. So if the denture does not fit good in the mouth, the tissue-borne guide will not fit good in the mouth. So that's one of the things we're just adamant on, whether we start with a new denture, whether it's an existing denture, whatever we're doing, it's got to really be able to fit on the tissue. Exactly. So we've got our denture, we've made our denture, and we know exactly where the teeth need to be. We can try it in the patient's mouth, make sure it's okay, and the patient's happy with where the teeth need to be. Then we're going to bring all that data back into the software and using the denture to guide the implant placement. One second. There we go. And on tissue-borne guides, like I said, if we don't get into the vestibules on the lower or the upper, then I can't make a guide. I need to make a guide that fits like a denture, and it needs to fit perfectly. The more information I get, the better I can make a tissue-borne guide fit. And we can always do fixation pins and all that other stuff. But if it doesn't sit firmly on the existing tissue, we've got a problem from the beginning. So if we've made a denture and the patient's got the denture, then all of our planning is going to be from that original denture. Now, this is where it gets fun because I'm not going to start over. So now I'm ready to do the guide for John. I'm ready to do the immediate load temporary for John. And he will know we've already made a denture, and he'll know that day whether he can immediate load. If he can't, then he puts the denture back in. If he can, then I'm going to, one of the biggest problems in implant dentistry is the conversion. So now you've got to take the denture out of the mouth. You've got to figure out where to drill holes. You've got to grind off all the vestibule, and that could take literally hours to take that existing denture and try and convert it and attach it to temporary cylinders and get it back in the mouth. And it's, I mean, I've done these several times, and it's a royal pain to be able to convert a denture. So we pre-convert the denture for you. I'm going to take the original file and I'm going to take it, and then I'm going to modify it, and I'm going to convert it. As you can see here, I'm basically leaving the palates and the vestibules out as little outriggers so it fits. I mean, it's going in the mouth, it's going to fit firmly into place, it's not going to rock around. But I'm also, from my guide, I'm going to take the information from my guide software and I'm going to bring that into the denture software and layer those on top of each other so I know where to put the holes. And I'm taking into consideration angled abutments on this one. So some of them are lined up with the holes, some of them are not, because I can pre-design my angulation so the holes are coming out where they're supposed to be. So I'm going to take I made a denture. I'm going to open up that denture back again. I'm going to go back into my software and kind of convert it, pre-convert it. And then I'm going to lay the implant software on top of that so I know where to put the holes in the denture. And it looks something like this. So I've got all this information layered up on top of each other. So we're going to mill that out and we're going to send it to the doctor. And it looks something like that. So the conversion is you still have to attach it, obviously, to the denture. But when it's attached very quickly, then you're going to unscrew it, take it out of the mouth, cut 4 or 5 little outriggers off, and it's converted and you're done. I mean, it's a 5-minute process rather than a multi-hour process to be able to do this. And everything lines up perfectly together. So here's our conversion denture, for lack of a better term. We're going to attach it to temporary cylinders, cut off the outriggers, and pretty much be done with it. And everything lines up very nicely. And we do this on a very regular basis. So let's take a case. So we're going to be doing implants on the lower on this case, and we're going to pre-design a denture. The doctor's already said he knows he can get immediate stability, so we're definitely going for a fixed temporary on the implants that we're going to be doing. Uppers and Cranham bridge already. Lower radiographs. This is a very classic case of posterior teeth being gone, anterior teeth still being there, and the bone being too high on the anterior. So there's two ways to reduce bone. And I think John and I agree that there's a whole lot more bone reduction going on than probably needs to be. one of the things digital allows us, because we get these cases in, bone reduction, bone reduction, bone reduction, and they're exciting, they're fun, they're really cool cases. But I would say probably 20% don't need it. They just, everybody's got a preconceived notion that, oh, we're going to do bone reduction on this case. And once we get it all designed, I'm going, you really don't need to do bone reduction, maybe some bone recontouring, but we don't need to be chopping off 5 millimeters of bone here. So yes.
I just want to comment on that a little bit. And again, I just want to chime in because this is something that, zirconia has, changed the game a little bit, because once we had minimal zirconia, you no longer needed 15 millimeters of prosthodontic space. And just understand that when you're, if you go to an evening class and they're talking about, the all-on-4 technique, and they talk about tabling bone a yard. I mean, I've been in those surgeries, and Lee says it's cool and all that. I don't like it. I do not like seeing people lose half their maxilla if they don't have to.
Sure.
And one of the things that's cool about the way we're doing it now, and we'll get into this when we do our all-on-4 talk, but being able to keep a few teeth for a while and put the implants exactly where the teeth were, you can make them a bridge essentially on 5 or 6 implants where they get to keep all their own gum. Mm-hmm. So there's no pink, or there's very little pink. And just think about that. So as you get on that road, just don't assume that everything is just a denture with 15 millimeters of space. It's gone so far beyond that. And then the other thing to think about is, and Kim Daxon's made this point, is, if you do chop all that bone off and the implants don't integrate, then what the heck's the patient going to do?
Yep.
Now they don't have anything. So I think that's a really good point. I just wanted to chime in.
Yeah, no, please. We divert, like I said, 20-25% of the cases away from that. But there's this, you take the class, this is what you do, you bone reduce, you do this, and I don't know, not on every case. Some cases definitely require it. This case requires it, but not to the extent. This is not a major bone reduction case. This is just kind of recontouring. But we know that from our digital plan. So I can tell the dentist surgeon, this is what I'm seeing. What do you think? So starting with a denture design. So even though, and we're gonna get all this scanned in, we're gonna put it all together. So the denture design to the upper. And on this case, we actually did this one slightly backwards, because we were working on the case, and before we even got to the planning, Lyndon goes, well, this is where I'd really like the implant holes to come out. I'm like, okay, I'll see if I can make the implant holes come out here. So again, placing everything, tying everything, CTs and dentures back together into the files. And then placing the implants to match kind of where he wanted them to come out. I was able to get it close. It wasn't perfect, but because the nerve was in the way on one of them, but actually we got really, really close. And then our final design for the implants. So we're doing kind of a modification of what John was just talking about. So we're going to keep teeth to, this will be a tissue-borne, tooth-borne implant guide. So we're going to extract the teeth where the implants are going, leave the rest of the teeth for the guide to sit on, and then we're also sitting on tissue. But again, bringing in all of these data sets together with the guide, the teeth, the dentures, where everything is going to go, and kind of putting all of this together, and then simulating bone recontouring. So I, on the STL model, reduced it down to where it needed to be. We were able to put that back into the CT, and then we were able to see very, very quickly, we don't need to grind off a lot of bone. We definitely need to even it up, but it's more of a recontouring than, flapping tissue, bone reduction guide, foundation guide, and because that's a very invasive surgery. So we're able to see this before we even started. And this goes back to the power of what we do with digital dentistry. We know what we're going to get into, good or bad, before we ever get into it. So we know how much bone's going to have to be reduced, where the implants are going to go, where the heights are, where the teeth are, got everything we need to know. And we're going to be sitting on teeth and tissue on this case. Now, with that, we can go ahead and design our teeth, basically extracting the tissue off, but teeth in the same place. Holes are going to be in the same spot. We've just extracted the tissue off, a little bit different design where I'm going to be sitting back on retromolar pads and that bony area right behind the anterior teeth in a tripod, so it actually sits very stable. But again, starting with a denture and then linking everything together. So no more conversions, or very, very minimal conversions. Now we're going to go ahead and print everything up. So we've got the models, we've got the guides, we've got the reduction. So the doctor can see how much tissue bone reduction there was to recontour. And on this one, he's actually going to place the implants to depth without reduction first, and then reduce bone down to the heads of the implants. But again, everything cross matches, everything cross occludes, everything matches up. All the holes are all the same. From the denture to the final to the converted denture, everything is very nicely lined up. So then extractions, guide on, implants in the anterior. Osteotomies to depth. Then the other teeth are extracted. Not a lot of major tissue moving. Checking with the denture just to make sure everything is lined up where it's supposed to be. Bone reduced down to the heads of the implants. And then completing all of the implants and then checking with the starting denture that we made. Implants are in, temporary cylinders are on. We're going to take the converted denture, slides right over the top of the implants. And this is why the planning is so important, because this part could either go really easy or really bad. So we've got to, if we're parallel, that's great. Parallel, straight abutments, straight temporary cylinders. If we're angling, we've got to make sure all of our angles are right, our timing is right. So even though our implants are tilted and non-parallel, the abutments that we're correcting with at the right angles and the temporary cylinders all come out parallel again. So the restoration basically just goes over the top and drops. Doesn't always work out perfect like that, but this one actually worked really nice because I was there. So now attaching, we've got a bite to make sure it's in the proper area. We're resting on 3 bone areas. We've got a bite to make sure it's lined up correct. And then we're going to attach the converted denture to the implants. And you can see they come out pretty much right in the middle of the holes that were pre-created. They've got a very even layer of composite around to attach. And then I added some composite real quick and we finished that case up. So that was using a denture the entire way through. Implants, fixtures, angled abutments. And then we take that same information and then just move it into our final zirconia restoration, which is here. And the final restoration for the patient. But all because of a denture, all because of kind of starting with that denture. So we're going to go right down here. And again, even with a more complex case, still starting with dentures. So dentures, fiduciary markers, double scan technique, setting up the teeth. Now this is bone reduction. We still do that. So the dentist definitely wanted bone reduction on this case. But the point that I'm trying to make is we were able to do it very predictably because we did start with dentures and move those dentures into the digital world and based everything we did off of those dentures. And then we were able to do the same thing, place implants. This time we place implants and then bring in that information to our bone reduction. Then we do the bone reduction based on the implants and then make the guides to follow that. So even though John and I both agree, we still do bone reduction on cases. So we've got the original teeth, we've got the teeth, we've got the bone reduction, which we've done with an additional STL. But again, all based on a denture. And then we're going to take that information, place the holes, and then convert the denture into the final prosthetic that sits on the bone reduction guide. So this is the guide, bone reduction, and the temporary that sits on the top of it to attach it to the implants. And the surgical guide fits on top of the reduction guide. So kind of taking you from the beginning, some of the things we did way back before there were even digital dentures, into the evolution of the thinking of creating a base and then gluing in conventional denture teeth, which never made sense to me. Some of the work we were doing, some of the work we teamed with Ivoclar with to kind of produce what we do today with denture teeth and bridge teeth. And then how we do that clinically, all the options you've got for starting out clinically, challenges you may have, how to fix those challenges, talking about printing versus milled and why my decision is based on one thing at this point. And then showing how dentures can help us pre-plan accurately placed implants. And again, so it's everything predictable. And there's one thing, learn from John, learn from Pete. Efficient, predictable. I like efficient and predictable. Sometimes things do get complicated just because of what we do, but the simpler we can keep the process and the more efficient with pre-planning, and we can use dentures and that denture software for doing all of these things. But like John said, if you've got the software that he recommended, you can go do a denture right now. You've got the software to do it. You can play with it just to kind of get a feel for how easy it is. And just, if you've got the right resins, because you will probably have to order at least a base resin, but you can make a denture next week. And if there's anything that I can do or we can do in questions about how you're going to do that, we can do that as we kind of finalize off the day. But I've tried to give you just as much information as I can, from the evolution to what we've done to where we are to all the different clinical options, and to answer the one basic question: is a digital denture better? Yes, a digital denture is. So thank you so much for spending your Friday morning with me.
Yeah, that was great, man. I think that where this is going today was really about giving you a big picture to make sure you understand the workflows at a high level, and also to understand what you need to be giving the lab for them to be successful, depending on which one of those cases. And if you're not clear about that, throw it up on the WhatsApp before the patient comes, and we'll make sure you get the right data up there. And then secondarily, as we go down the road, as you guys develop mastership with the software, however far you're going to take it, we'll make sure on the inside of Teachable that we'll have the step-by-steps of doing a denture and printing a denture, that we've got all those things in there for you. That's being built now. So, and I think actually Thor's case is the one that we're going to be taking kind of through. Is that right? Is Thor's case? Yeah. So, yeah. So with that, I think the only other question we had was from Gloria. And I think you were showing one of the implant cases, and the question was, were those temporary cylinders opaqued in the photo. Do you usually opaque your temporary cylinders?
Uh, So yes, Dr. Cooper did opaque those. I don't know if it would be regulatory correct, but yes, he did put some white out on them. I don't think he needed to because that was a very thick PMMA, so it wasn't going to show through anyway. Normally we do not. When we do them in the laboratory, we do go through a very particular process, but we do lightly sandblast or air braid. And then when we bond them in the laboratory, whether it's PMMA or zirconia, there's a series of chemicals and steps we go through. But rarely do we, well, not rarely, we never opaque the cylinders because these restorations are usually thick enough that you wouldn't see it. And
yeah, if you see through them, I would think that it'd be pretty big chance that you'd have a fracture right there.
Yes, you're too thin if you can see the cement.
Yeah. Okay. And then the last thing that I was just thinking that we might want to make a note to ourselves, what was the name of that system, that pickup system, when I happened to be there that day, that guy was there, that where he does the pickups?
Yeah, so we're gonna, and I've actually talked to Brandon.
Be a good little video.
So we're gonna do a little shot on that. I'm gonna do a case with him here, just to kind of document the whole thing. So it's kind of a combination. So I'll try to explain it as best I can. And I'd give you the website, but I forgot the exact name of what it is. But Jonna, I'll explain it a little bit. I'll get the exact name and then we can share so they can kind of go take a look on the website. But what it is, real quick, is if you're just going to convert a denture, then he has little abutments that you use a marking medium and kind of place it on top. So it shows you where to mark. You do go and ream out using his technique. We're actually kind of marrying our two techniques now. So you ream it out so it fits down. And then
and I'll just interrupt. Think about what he's describing is almost like if you were going to pick up a locator under a denture. It's very similar. Yeah. Okay.
Yeah, no, good. Yeah, good analogy. So then you pick up the abutments. Now the problem is there's no screw access hole. So once you've luted them on, it basically snaps into place. It snaps back off. You turn it upside down, and then there's a series of drills that you just go from the bottom and drill from the intaglio surface out the top. So you get the little tiny holes. So mine, when I make them, have big holes. So we're actually kind of marrying the two techniques together so you don't have to go grind the bottom out. But basically, you're going to pick up the little caps on the abutments, you're going to take it out, snap it out, you're going to turn it over, and then there's a series of drills where you drill through the bottom, it puts the little tiny hole at the top, and you're kind of done. It's kind of a cool system.
So it basically, when you're doing a pickup on an all-on-4, it ends up being that you just have little tiny screw access holes, and it makes the prosthesis a whole lot stronger, which I think is pretty cool.
Yep.
But anyway, so let's, I think we can wind up there. I will hit record or download this thing and probably cut it up a little bit, cut the little breaks out and get it up by the end of the weekend. But great first lecture this year, Lee. The next one, I'll be talking about just kind of workflows in the practice and best practices to kind of get the whole team. And what I would suggest on that one, it might not be a bad idea if you made like a little staff meeting and had the team watch it. That might be a good thing. And of course, that one will be recorded too. Any questions, follow up, throw them up on WhatsApp and we'll hit them. But for now, we'll see you later. And Lola, I'll see you online in a little bit. All right.
Great.
Thank you, guys. Appreciate it. Thanks, Lee.
Good day, good weekend. Happy Valentine's Day.
Yeah. All right. Take care. Bye.
Bye.